Hello again, dear friends. Today is my pleasure to introduce you my friend and colleague, Dr. Miguel Milan, that he's going to talk about non-invasive POC. Miguel, please, whenever you want, the floor is yours.
Thank you. Thank you very much, Nasser, for this nice introduction. And yeah, we are going to talk about this topic, that is the use of liquid biopsy adapted to cases of miscarriages. So this is my disclosure, and I would like to start with these two questions that when it comes to pregnancy losses are very frequent. And the first question is, why this happened to me? And the second question is there anything that can be done just to avoid this to happen again, right? And this is a very important topic because pregnancy losses cause, a huge psychological impact in families and in couples. And it's quite important, and it's been described that it's quite important just to detect these severely affected couples, psychologically affected couples, just to be identified and just to find tools for a proper management so these couples can move on. But when it comes to have these tools and do testing on these couples, no guideline, no professional guideline endorse the use of any sort of testing in isolated pregnancy losses. But this is true that in this specific guideline, is recommended that, is stated that it could be done for explanatory purposes, right? And it makes a lot of sense because whenever it's well described, you can find, a lot of scientific literature regarding how beneficial it is just to find out the etiology for these pregnancy losses, helping to alleviate this psychological distress that this couple have, and helping this couple just to have a proper closure. So, and these pregnancy losses is not a rare event. So it's been estimated that depending on the setting, among 15 to 25%, up to 25% of the couples having a pregnancy may end in a miscarriage. And if these bars represent all the possible factors contributing or causing a miscarriage, there is only one that accounts for more than 50% of all the pregnancy losses, more than 50%. So make a lot of sense that whenever we want to start doing testing in couples just to find out the etiology for these pregnancy losses, that we start doing genetic testing because we are going to save time and money, okay? And this is very important for the couples. But what happened? The situation is that so far, to do this kind of genetic testing, what we have to do is just to get the tissue. And getting the tissue is not always a trivial thing. So many times what we get is a tissue in which we can recognize the placental or the fetal structures, so it's okay. But sometimes what we can see on the right is that we receive a tissue that the vitality is not good enough to do certain genetic testing. And on the other side, we cannot recognize easily this fetal or placental material, and we have maternal cell contamination. And it's well accepted that in general, when we do dilatation and curettage or aspiration or whatever, just to collect this tissue, and we do molecular genetic testing like NGS or chromosomal microarrays, we will have 20% of maternal cell contamination. So 20% of patients not having a result, When it comes to other kind of testing, like karyotyping, we can end with a more than 50% of non-informative cases. So this is our situation. This is the fact number one. And the fact number two is that worldwide, if we think worldwide, the situation is that the most extended practice is not to collect this tissue to do any sort of testing. The most extended situation is just to give a medical treatment, the misoprostol or the cytotec, just for the lady to have this induced evacuation privately at home. The reasons behind this, many different factors. Some of them, you can see these factors listed in here. In some cases, the doctors, they don't know how to do the dilatation and curettage, or they know how to do it, but the facilities are not ready just to perform this kind of procedure, so they have to take the transfer the patient to another colleague or another center to do that, which is not convenient. Another factors could be that they don't want to take any risk that is associated with invasive sampling. And the last is that the most standard is that many times doctors, they want a safer environment for the lady just to have this evacuation at home and move on psychologically, right? So at the end, what we have is that the majority of pregnancy losses remain untested. And if you talk with the doctors and patients, and you say, okay, would you like to have this result? Would you like to know if the reason behind this pregnancy loss is an aneuploidy, a chromosomal abnormality? The response is yes. The answer is yes. So we were encouraged by our doctors and our collaborators just to develop this liquid biopsy approach for pregnancy losses, that the name is NIPOC, and this acronym stands for non-invasive POC analysis, product of conception analysis. And it's a simple blood test. So if you are familiar with an NIPT, the non-invasive prenatal testing for ongoing pregnancies, technically it's very similar. So what we do is just to draw a blood sample. We isolate the plasma and the DNA, we sequence the DNA, and at the end of the road, what we do is just to analyze bioinformatically all this cell-free DNA that we've isolated with an adapted algorithm. And this is very important. So we cannot do the analysis as per an NIPT for ongoing pregnancies because the intended use and the population is completely different. We are talking about miscarriages in which the fetal fraction is going to be lower and the prevalence of the diseases or the aneuploidies are going to be higher. So this algorithm, this diagnostic rule should be adapted. And this is what we did. We did this adaptation based on the knowledge that we had. So there are several articles in the scientific literature that you can find describing the experience of using cell-free DNA in cases of miscarriages. These latest hours that we published last year in 2023 in the British Journal. And what is clear, which is crystal clear, is that using the cell-free DNA and doing the analysis as per an ongoing pregnancy with an NIPT is not enough. So the sensitivity that we are getting is in the 50s, 60%. So this is quite similar to which we have currently with the karyotype. And we want something better. So it's necessary to adapt this algorithm. This is the validation that we did with our adaptation for this miscarriage population. On the right, you can see that we did the analysis in the tissue as a reference or gold standard, and then we analyzed the cell-free DNA in the blood from these mothers just to see the concordance rate. And you can see how the concordance rate reached close to 90%. And the sensitivity and the specificity, you can see that is 90% and 97%. So nothing to do with these 50 or 60s. We go to 90%, okay? Excluding triploids. We will talk about this later. So the benefits are clear. First, it's not invasive, so you don't need any surgical procedure. Second, it's fast. We are releasing the results. Our commitment is 7 working days, but we can release, and we are releasing the reports in only 3 working days, as we do for the NIPT service that we already have. And it's very informative. So if you pay attention to the gold standard in many locations around the world, that is the karyotype, the informativity is around 50 or less, and we are getting an informativity close to 90%, similar to other approaches, molecular approaches like the NGS or the CMA that you may find in the, when you do the studies in the tissue. So obviously, you know the benefits. You don't need to do any surgical procedure. Whenever you want to do this kind of testing, just for explanatory purposes or whatever, obviously, you are going to avoid any kind of risk associated with the sampling. The patients will have just a reason, just to know what happened, and will have a private evacuation because they can take this medication after the blood collection at home, and it's safer psychologically. In 50% of the patients will have a reason, just to tell and explain what the reason for this miscarriage was. And we will have information for prognosis, because obviously it's much better that the embryo has been arrested because of an aneuploidy, because that means there is nothing to do with the family, with the couple, or in the environment that is not baby-friendly. So it's much better that the reason is the embryo at this point, okay? Regarding the limitations, if you are familiar with the NIPT and this kind of analysis of liquid biopsy in the blood, are exactly the same. The only thing that I want to point out is that the triploidy is not detected with this kind of techniques. This is a sort of limitation. And regarding indications, that for sure is important for you. The indications are clear, so if you stick to the guidelines, obviously recurrent miscarriage whenever you don't have this tissue, okay? The second is obviously if you want to do the testing for explanatory purposes, you can do it in any single an isolated pregnancy loss. But we think that could be very convenient in the IVF population, and this is the third indication, for 2 main reasons. The reason number 1 is because obviously triploidy is a limitation of this approach, but triploidy is much less important in the population, in the IVF population. It's been described in the scientific literature that the triploid miscarriages account only for 1 or 2%. If you compare this with the regular pregnancies, in which the pregnancy accounts for 5 or more %, okay? And the reason number 2 is because this could be a new decision-making tool. Why? Because the IVF patient is not a regular patient. It's not a regular couple that they want to achieve a pregnancy. They have a lot of different burdens, starting for psychological burden. Then when they decide to go through an IVF treatment, they have this physical and economical burden to going through this IVF procedure. And then they have a miscarriage. And I recall to the first slide. So now comes the two questions, the two main questions is, why this happened to me, and is there anything that I can be done just to avoid another miscarriage again? And the answer is yes, we can do this kind of analysis that is simple and straightforward. You don't need any facility, a special facility in your centers. It's just a blood test that we can do just to find out if the miscarriage was due to an aneuploidy, and in this sense, what we can do is just to have an interview in the context of a genetic counseling with the patient, discussing different scenarios, just to reduce in the next attempt the likelihood of having a miscarriage, because this is what the lady is asking for, right? Or in the case if normal, we have the opportunity to review carefully this medical record, and altogether, this information is useful because a percentage of these ladies, they are going to become recurrent pregnancy loss patients. And for me, it's totally clear that the management is going to be weaker when you have a recurrent pregnancy loss patient in which the miscarriage number 1, number 2, even number 3, you don't know what the reason and the etiology for this miscarriage is, and you do a management only based on the last one. So based on this information, this genetic information, you are going to do a management, right? So obviously, you can see and you can think that some patients are equivalent, when the reality is that they are not equivalent. And the management could be stronger if we have the big picture in front of us. And it's important, I think it's not only important for the clinical point of view, but it could be even important from the scientific point of view for research. Because obviously, it's been described by several authors that it's important just to, whenever we want to do research for certain management or treatments, just to isolate and differentiate which population is with miscarriages, and the miscarriage was due to an aneuploidy, and differentiate this from the aneuploid miscarriages. And why? The reason why is because this could be a confusion. The aneuploidy could be a confusing factor that can be diluting the results. And at the end, we can be drawing wrong or weaker conclusions. So the messages to take home can be summarized in this one. So obviously, miscarriage or aneuploidy is the main factor contributing to these miscarriages. So it makes sense that if we start doing any sort of testing, we start doing genetic testing. This new liquid biopsy adaptation for miscarriages, the intended use obviously is for miscarriages, but it's not intended to substitute all the analysis that we perform in the tissue. Okay, so this is just a complement of these techniques that we already have for those ladies in which the tissue is not available. So now we are broadening the amount of patients that can get this aneuploidy assessment. And the simplicity, obviously, this is liquid biopsy, which is synonym of simplicity, right? So it's simple, it's straightforward, it's accurate, and this could help our patients to alleviate the psychological distress. We can understand better the prognosis for next attempts. We are improving the clinical management. If we know that this is an aneuploid, we can do something in the next cycle, just to reduce future miscarriages. Obviously, we are going to create this perspective for patients that become recurrent pregnancy loss patients, and we are going to improve, in case you are a researcher, a scientist, and you are doing some kind of research, your patient selection in this kind of studies. Finally, let me say thank you to all the phenomenal team that is every day doing clinical and research for this kind of pregnancy loss cases, and that they keep developing new things. And that's all. Thank you so much, and I will be glad to answer any questions that you may have.
Thank you very much, Miguel, for this fantastic presentation. Is there any questions? Because I've got one this morning from a doctor asking when. So what if the patient had a miscarriage at home? Can I do the blood draw a few hours later?
No. No, it's been described in one article last year too, that it's possible to get the blood up to 12 hours since we have the evacuation of the fetal remains. we don't recommend to do that. It could be done in certain patients with certain characteristics, but the reality is that the cell-free DNA, whenever the fetal remains are outside the body, the cell-free DNA is being released minute by minute. So one of the problems with this miscarriage population or pregnancy loss population is that the fetal fraction is low. It's lower. It's like 50% to the fetal fraction that we may expect for the ongoing pregnancies. So imagine in this situation, we are going to have more low fetal fraction. If no tissue is inside, so has been evacuated, the cell-free DNA is going to be lower and lower and lower, and the amount of non-informativity should be higher. And the sensitivity, it would be impacted for these low fetal fractions too. This is technicalities, but this is one of the consequences. So we don't recommend to do this sampling, this testing, unless the fetal remains are inside. So the perfect procedure for this should be just to check that is a miscarriage, check that the fetal remains are inside, and then collect the blood before the fetal remains evacuation and before the medical treatment. That we don't know what is the effect and the interaction of this treatment with the analysis. Just in case, until we know this, we prefer not to include these patients.
Okay, perfect. Thank you. Anyone else? Okay, so thank you very much, Miguel, and see you all in half an hour. Thank you. Thank you.